I think they'll mention this just because it was mentioned before for dermatology. I think the remuneration for, let's say, a general surgeon could start at 200 and go up. And then, of course, if you go private, really the sky's the limit. I think McDreamy on Grey's Anatomy makes 1.2 million, if I'm correct, in the United States. But then again, you know, just like what they say in Spider-Man, great power, great responsibility. So, you know, if you mess up in the operating room, the patient's going to know. The patient will remember you. There's my slide against anesthesia. So as you can see, I represent sort of a big umbrella term, and this is me, orthopedic surgery. I am not a podiatrist, okay? Not that I have anything wrong with podiatrists, but I don't just, you know, shave off corns and prescribe Dr. Scholl's pads. I'm a musculoskeletal physician. Patients come in with fractures, we put them back together. They come in with arthritis of the hip, we replace their hip. Sports stars come in with injuries, we fix them. Tumors in the bone, we remove them, and we still make the patient walk. But as you can see, if you're interested in intervening in patients directly, you can operate in any single part of the body. And some come with different lifestyles, different expectations, different follow-ups. My advice to you is if you're interested, get some experience while you're in medical school, spend some time, do an elective, figure out if it's right for you. So in medical school, you do get a lot of exposure to surgery. They actually make you spend 2 months in general surgery. In general surgery is sort of abdomen, a little bit of the thorax, really depends, thyroid as well. And then they also make you go through obstetrics and gynecology, which does have surgery. And then in 4th year, you have to go through a surgical subspecialty. And then finally, of course, it's 5 years in residency. And just like surgery residencies are just like any other residency, the first year you're sort of bouncing around from each service to see a little bit of everything. And then the next 4 years you're in whatever field you're in, and that's all you do, and you become an expert. And then if you want to do fellowship, surgery is really like you sort of, you know, the horse with blinders, and then the blinders become even more narrow. So at the end of orthopedic surgery, I'll be able to handle most musculoskeletal problems. But if I just want to do shoulder reconstructions and work with, you know, baseball stars, that's all I can do a fellowship to do that. If I just want to be a trauma surgeon who handles people in car accidents, I can do that. I can really be an expert in one or two specific techniques, but of course still have the ability to cover most bread and butter cases. So it's very nice because it certainly reduces the stress later on, because you know you have a sort of routine number of cases and you can really become an expert in that. So this is what the medical school rotation is like. Medical students come in, they have no idea what to do, they don't understand this concept of dressing up, and so usually one of the scrub nurses helps them dress up, and then they come in the operating room, and they're nervous, and they're sweating, and they're itchy, and they'll spend 10 minutes getting changed. Okay, I did it right, turn, they do all these things. Phew, I feel great. And they'll wipe themselves or scratch their nose with their glove, and that's it, game over. You gotta take off everything and do it all again. And they'll come in and they'll go, "Hey, Mr. Smith," and they'll touch him on the hand, and you're contaminated, gotta do it again. So it's a bit of a routine to get used to the operating room. But you know, you'll learn eventually. So can you guess where the medical student is here? So here's I guess here's the surgeon, or here's the attending surgeon. Here's the chief resident. Is that the medical student who's eagerly looking and figuring out what's going on? No, that's the medical student right there, falling asleep, looking at the back of the chief resident's head, wondering when is this going to end? And that's what you have to understand. When you're a medical student, you're not going to go right in there with a scalpel, cut here, divide here. No way. What you're going to do is you're going to watch. You're going to learn. And then, if there is something that has to be done, if they need your help, you're going to help. You're going to suction. You're going to hold the heart. You're going to suture up the wound if the wound needs to be sutured. You're there to help, and you're there to observe and sort of take in information. So it's a little bit different from other rotations where you're sort of given patients and let loose and do whatever you want, and I'll sort of watch over you. Here, mistakes cannot be made. So here, the medical student observes, and as the surgeon feels more comfortable, then more responsibility will be given on the medical student. So you have to be patient at the beginning, but then, if you're patient, it will pay off. And so this is what you'll be learning. It's basically how to do stitches, which actually takes a little bit longer to do to become good at it. And then when you're in the operating room, you're going to fumble around and not do a good job, and that's fine. But of course, you're still babies, and so, yeah. And Dr. Cole, I like that. And this is your first steps. And even through residency, when you're a first-year resident, you still feel like this. You're still in diapers. And with time, you'll mature and you'll feel better. So again, as I said, core year, you have to sort of move around, and then in subspecialty, you become a competent specialist. So when do you start? Okay, you don't have a lifestyle of a radiologist. You do start early. And this is mainly because you have to see patients, and the operating room starts at 7:30, 8 o'clock. So the whole team will assemble at 6 o'clock, sometimes earlier, sometimes later, depending how many patients you have. You'll see your patients, wake them up. How are you feeling? Feeling good? Wounds good? This is good? Vital signs? We're not talking about how their niece or nephew are doing. We're very cut and dry. And then what we do is we go to the OR. The senior residents and the staff go to the OR and they operate. Senior residents being 3rd, 4th, 5th years. The juniors will either observe, or what's most likely going to happen is they will go back and take care of whatever needs to be done for those patients. And then they'll go to the ER and see whatever patients come in. And you might be thinking, well, that's not really fun. I want to operate. You will operate, but you have to learn how to take care of patients. Because being in the operating room is certainly a big aspect of your life. But if you're outside of the operating room, you don't know what to do, well, then you're useless. So there is a little bit of a learning curve. So this sometimes happens, okay, sometimes. If you're a senior resident, usually. If you're a junior resident, it really depends. Because when you're especially an orthopedic resident, in the winter time, wow. I usually don't go outside. I usually don't go over the snowbank. But today, I didn't wear my boots, and my dog ran, I slipped, and I fell and I broke my wrist. So in the wintertime, we actually see quite a lot of work. But then, of course, you have call at night, and call as a surgical resident is interesting because as a senior resident, you do, as Andrew was saying, your lifestyle does get better. You go home, and then if the OR is needed, you start coming in and you operate. When you're a junior resident, you're the guy who takes care of the floor and the ER, no matter what comes through. And sometimes it's quiet, and you go home and you see your family. And sometimes you're there all night. So it really depends. And you have to understand, yes, there's lifestyle, but you got to learn. And most of the learning that you'll do in residency is when you're on call. When you don't have all those supports with you. When you're the one who has to put in the IV for the first time. When you're the one who has to go ahead and put the cast on, or who knows, do some sort of intervention, put a chest tube in. When I did that for pneumothorax. Yeah, the heart was beating there. But then when you do it, when it happens in the day, you're the pro. You know what to do. And so although it's a little bit stressful, there is a learning curve, but you do learn and you do become an expert in what you do. There is a hierarchical system of information, just like any sort of medical team. Again, team-based approach. And it's exciting because we're all sort of learning together. We all are sort of gung-ho people who want to impress our attendings and become technically competent. And it is a little bit competitive, but it's also collaborative. And again, I'm just going to talk a little bit about research and surgery. So here's sort of this little schematic of what it's like. And what I've sort of noticed is that for you who are interested in going to medical school, I guess the bulk of you here, that a lot of people are saying, well, maybe I should do a PhD or a graduate degree in medical school. Now, I know some people who have done this and have actually had a very good experience with it, and it correlates with what they want to do. They don't want to go into clinical practice, they want to work for a company. Great, research is great. Or they know what they want to do. I want to be a neurologist, and so they do a PhD in something associated with neurology, and then they go ahead and do that. Now, there are some people who don't know what they want to do. They spend 4 years becoming an expert in molecular signaling of cancer, and then they become a psychiatrist. So then what they did doesn't really correlate with what they're going to be doing, even if they're interested in doing academics in psychiatry. So I heard some people have told me, oh, well, the MD PhD program is easier to get into. Not many people go in there. They all want to be doctors. Nobody wants to be a researcher. Well, just hold on and really think about what you're doing before you go ahead and just decide to do it. For me, what made sense for me is that once I became a resident, and I knew I was going to be an orthopedic surgeon, that's then when I wanted to learn how to do research. Because the nice thing for me is that when I'm in the operating room and I see something that's interesting, I've never seen it before, I want to study it, I want to get better at it, and that's what a lot of surgeons are doing now. They're doing a lot of graduate degrees in their residency or after their residency, so they can become better researchers and help their patients. So do we have a life? Well, when you're on call, it's really variable, but otherwise, absolutely. Surgical residents are very well-balanced people. Take a look at the orthopods, we're all big, tall guys. We all go to the gym a lot. We talk like this, and we walk around like we're tanks. And then you'll see the neurosurgeons who are very cerebral, and they're like, well, the intracerebral pressure. And then you see the OBGYNs, the whole time they're just running all over the place. So So every surgical specialty has its flavor, but what you'll notice is it's sort of like what Laura was saying. You sort of meet your group, and everybody who has similar interests with you, you sort of bond. You spend a lot of time